Well, good morning. It's a pleasure to be here for a number of reasons. First, because I'm not used to speak to such an audience. Actually, I'm used to speak to immunization specialists, so I'm looking forward to the interaction. And second, actually, even if there has been some level of out-migration after the previous talks, in this room, it's more rewarding to speak in front of this audience than the last one I was confronted with in Spain. The conference we were at will remain unnamed, but actually right before the session, we're having a bet with the other panelists if the audience would actually total up 5 participants, that is including the 4 panelists. So it was a bit discouraging. Here is the outline of what I will go over. Actually, I'll tell you some about the processes we use to derive global policy recommendations for vaccines and immunization. I'll allude to the use of grades, and then I'll focus more specifically on the process of updating recommendations and very much dealing with emergencies and situations with a paucity of data, because Mark actually wanted me to focus on that particular issue. So first, to talk about the setting of global policy recommendations, we have to put it in its real context. Yes, we do provide recommendations at the global level, but these are only recommendations. They don't drive the action by countries. And it is important to keep in mind the various layers at the global level, at the regional level, and at country level. At country level, where decisions are made, and a lot of our activities at WHO are to support the development, the strengthening of the decision-making capacity at country level, so that they can, of course, use our recommendations, but adjust them in the local context, which is extremely important. I will be focusing on the Strategic Advisory Group of Experts, which is our main advisory committee, but to keep in mind also that we have other more specific technical advisory groups, which work actually contributes to that of SAGE. The first thing I want to say, and some of you may be familiar with this committee, which reports directly to the Director General. Over the last 5 years, we have completely changed the process of operating of the committees. We've tried to make the committee more transparent, more credible, and thereby having more of an impact on countries, on our primary target audiences. The committee now is basically made of 15 members. There's a serious process of identifying the best experts to serve on the committee. We have an independent selection panel, and the experts serve on their individual capacity, but do represent a broad range of expertise, affiliation, and geographic representation. We put a lot of emphasis as well on the declaration of interest of the members. I think it is important to have this neutral forum. With respect to meetings and operational procedures, the committee meets twice a year. This is important to keep in mind when dealing with emergency situations. The committee functions under a transparent process, i.e. these are open scientific meetings, open to the scientific community. And we have a fairly extensive participation from partner organizations. The process is evidence-based, and there are as well working groups. I'll be a bit more specific about the purpose of the working groups. A lot of emphasis is put on the reporting and the communication. And with respect to transparency and communication, I just want to say that all the evidence that's put before SAGE is made public on the website right after the meetings. Here are the pathways for the issuance of WHO recommendations on vaccine use. This may seem a bit on the complex side. I just want to say that with SAGE in the middle, again, as I said before, SAGE is not alone and benefit from the reviews, specific technical reviews by various committees that are on purpose made independent from SAGE itself. At the top, you can see the process by which information is fed through SAGE, and more we count again on SAGE working group to review evidence when the evidence is fairly complex. So the purpose of this group is to have a comprehensive review of evidence, pre-digest it, and bring it to SAGE for decision making. But as we have seen on many occasions, and invariably the working groups are more disease specific. So they tend to be more favorable to a particular vaccine or a vaccine prevention program. And really when it's brought to the SAGE forum, which is more neutral, I mean, we see at times a divergence of views in the recommendations. And what is also important to keep in mind, I should have insisted on that yellow box at the top right, because vaccines are not alone in terms of prevention tools even for vaccine preventable diseases. And it's very important to also keep in mind the other non-immunization related potential interventions, and to factor all that in before a decision is taken in issuing a recommendations. That's really fundamental. So the SAGE working groups, I told you a bit about them, but what is essential to keep in mind is that these groups are not the ones that eventually will decide on the recommendations, and they are not empowered to speak on behalf of SAGE, nor to communicate their interim deliberations. Again, it is only communicated after a decision has been, recommendation has been made by SAGE and provided to the organization. Now, what are the issues taken into consideration by the committee in developing recommendations? Well, as you will see, I mean, this echoes some of the comments that were made after the previous talk. Of course, one looks at the epidemiologic features of the disease burden, the spread, the epidemic potential, the diversity of strains, and so forth. One looks at clinical characteristics, at the severity, at the impact on the primary, secondary, tertiary healthcare system, at the sequelas that people may be left with. One look at vaccine and immunization characteristics, but this clearly goes way beyond the issue of effectiveness and safety. Indeed, these two elements are very important, but by far are not the only one. I mean, the acceptability of the program, the ability to reach a particular target age groups are very important elements that then factored in with the effectiveness of the vaccine will basically drive the impact you can have on the disease with your program. Economic considerations, certainly cost effectiveness analysis, although we are often lacking such analysis in developing countries, but very much as said before during the discussion, the sheer vaccine cost and affordability of the program, which is really far from a trivial issue. The list is not limited. It continues with also thinking about health system opportunities, the potential for interaction and building on existing intervention and control strategies. I mean, in a developing country in the middle of nowhere, you are not going to go and have many contacts with the population. You just try to minimize these contacts. We need also to think about the social impacts, legal considerations, as well as ethical considerations. That's very important, and I don't have time to go over these in detail. Now, the recommendations, when they are issued to SAGE, are made to the organization, and what we do now, we use these recommendations to drive the recommendations contained in our vaccine position papers that are WHO recommendations. These are the key documents where we put our policy recommendations for countries, and we're trying to make sure that every document produced by the organization is consistent with these vaccine position papers. In the past, we had some odd differences between various WHO documents, including at headquarters level, and that was really embarrassing. The position papers undergo a fairly lengthy development and review process. Again, SAGE is at the heart of this process, but is by far not the only group involved. And in terms of format, then we provide information on the disease, on the vaccines, and then the WHO recommendations. Also, there's additional posting of information on the website And that posting of information include the grade table, the grading of recommendations, assessment, development, and evaluation, as well as reference, summary information, PowerPoint presentations, and background documents or systematic reviews at times when they are not otherwise published. Which then brings me to the question for you to basically score. And if you could turn your attention to that, I'm quite interested with your view. So how is grade suited to public health interventions? And I'll ask you to attribute a score from 1, very problematic, 2, quite problematic, 3, neither problematic nor well suited, 4, quite well suited, and 5, ideally suited. It's interesting. I must admit I was actually not expecting this type of answer in this audience, but it actually confirms the view of SAGE. Because as we had started to use the process since 2008 and we use grade tables in support of key recommendations, all of a sudden we had concern expressed by SAGE. And the concern was as follows. I mean, they were concerned that grade was not doing justice to immunization as a public health intervention, that you could not reflect very important evidence, and that it was giving undue weight to randomized controlled trials. And that on the top of that, then it could be misused in particular in funding allocation by some of the approaches being used, and that could be actually a major blow undue blow to immunization programs. Actually, at that time, very few national advisory groups on immunization would use grade or even a formal rating process. Canada used its own approach. US at the time was considering the use of a modified grade, and since have adopted the use of a modified approach. So because of that, SAGE wanted us to establish a discussion group to actually develop first a communication strategy to mitigate any potential deleterious effect of a narrowly applied grade. And more than that, and more importantly, to suggest appropriate adjustments to the process. For example, by applying, modifying some of the criteria to increase or decrease the quality of evidence. And SAGE supported the development of a paper actually describing the process, and of course encouraged partnership with other immunization advisory groups as well as the grade working group. So in April 2011, we actually had more or less completed our work and were able to present SAGE with a paper on the development of evidence-based recommendation on vaccine use. And that follows, again, extensive interaction with the groups that I mentioned. And the adjustments were made to try to accommodate vaccine population effect, as well as surveillance and vaccine safety data, which was seen as a problem before. And during that session, we requested SAGE feedback on the adjustment to scoring. And we wanted to know if the output sufficiently addressed SAGE initial concerns. Here is the cover page, basically, of this guidance document, which has been now posted on the website. That's a document that will evolve over time. Of course, it's not set in stone. I just want to show you some of the adjustments that were made. I mean, the first may seem trivial, but for those of you familiar with grade and hopefully, I mean, the entire room here, I mean, randomized controlled trials enter at the 4 level, whereas observational studies do enter at level 2, i.e. low level of evidence. And the adjustment we did actually was just to clearly reflect that disease surveillance and post-market surveillance data were actually a form of observational data. It is actually amazing to me how in the grade wording and the type of wording that's used by our immunization communities, I mean, the wording tends to be completely different. And at times, they're talking about the same thing. But if you don't bring the bridging of language, it just doesn't work. A major issue at the issue of dose response, which, as you know, is more on an individual basis. But here, after discussing with the GRADE working group, we ended up considering the dose response as population effect. So we would upgrade if there is evidence of decreased risk with increased vaccine coverage, including evidence potentially of reversal at population level, i.e. when the vaccine coverage decreases, the disease returns and so forth. And there's still debate on that. We would further upgrade if there was very strong evidence of such a decreased risk with increased coverage. Also, there was a major discussion about the ability to upgrade observational vaccine safety studies. For the studies that would show an effect, it was okay because of the first criteria. But for those that would have a negative result, it was actually very difficult because you could not upgrade on some of the criteria and the first would actually not apply. So following discussions with GRADE, we're able actually to gain acceptance of the ability to upgrade, according to the design to control for confounding and avoid biases. So these were actually the major adjustments or the only adjustments that were made. With respect to communication, although also SAGE became allergic to the concept of very low, moderate, and high level of evidence because they thought it really could be unduly misused. And this is what everybody was comfortable with, talking in terms of level of confidence with respect to the estimate of the effect on the health outcome. So this is just a summary, and this is just for reference, obviously hard to see, of the criteria that we're using. Again, for those of you familiar with GRADE, this is essentially the GRADE tables with some wording adjustments and the adjustments that I've just mentioned before. With respect to the recommendations part of it, we don't actually use the GRADE scoring for the recommendations. Why? Because over time we have realized that countries are not so keen to have recommendation. If we tell them, well, perhaps you can use this vaccine, they go back to us and they say, well, tell us what you want, what we should do. You're not helpful to us. So they want either no recommendation, because we cannot provide the recommendations based on unfortunately, too limited evidence, or they want a rather strong recommendation at a given time, and then that can be revisited over time as evidence evolves. So we need this consistent and clear wording. So finally, the outcome is that SAGE was quite satisfied with the process. They were not ecstatic, but at least it put some of their fears at rest for the time being. And they just want us to continue interacting with the SAGE working group and trying to further optimize the process. And very much part of the issue, I believe, is that issue of bridging language differences. And everything that I've presented for immunization, some of the issues of the adjustments of the worries, I think it's exactly the same for any public health prevention issue. Now, let's move to the issue of updating of recommendations. I mean, this is really essential. This is essential because we need to reflect the best data available and update recommendations, particularly for immunization, for public health programs, after experience is gained after vaccine use, and we can really monitor the real impact versus the theoretical one. And over time, the issue is not just to bring new vaccines to the table. I mean, the issue is really to optimize programs and to try to reduce the cost. So if a vaccine is recommended by the manufacturer with 3 doses, why not explore if 2 doses could do well and save a lot of money? So we also have a process for position papers to review them and periodically determine if they are due for a full or a brief update. Now, of course, in the midst of all that, there's an issue of resources, because we're all confronted with resource problems. So we have to be pragmatic in that process. Now, I'm going to move to the issue of emergencies and real paucity of data. Before doing that, I'd like to ask you, in your view, what constitutes a public health emergency? The Haiti earthquake and the related cholera outbreak that occurred last year, the lack of stockpiled meningococcal vaccines intended to prevent outbreaks of meningitis in the sub-Saharan meningitis belt, or the estimated around 453,000 children dying from rotavirus each year, according to a paper published yesterday in The Lancet, or all of the above. So please do give me your score. Okay, so interesting results as well, and I would concur that all of the above are actually emergencies. I'm actually surprised with the low score for number 3, because what you don't have as information, but if you like, if you want to know the deaths related to the cholera outbreak in Haiti, actually, I believe right now we're probably at 6,000 deaths due to cholera, which is very unfortunate. But 6,000 deaths compared with 453,000 children dying in a given year. And for the meningitis belt and the meningitis epidemics, also on the epidemic years, we're also talking about a few thousand deaths actually, but that is of course within vaccine intervention in the context. And if I now ask you to tell me what constitutes, if we agree that all of the above constitute emergencies, what constitute the most important public health emergencies? Again, the first one, the second, the third, or the fourth? Of course, I substantially biased your answer with my previous comments. I think I did. Okay. I think that was a real bias. But no, seriously, I also think this is really what we have to keep in mind when resources are limited. As tragic as the initial settings, in these settings, it's very easy to find funding because it's obviously to the public an emergency situation. When it comes to actually trying to help the developing countries combat these between 400,000 and 500,000 deaths, then it becomes very difficult to find any resources. And yet, in comparison, I mean, there's no comparison in the amount of death that you can prevent. And any one day of delay in introducing a vaccine program, or any week of delay, I mean, you can total the numbers of lives lost easily. So talking about emergencies, I think we are always in public health dealing with emergencies, or we should be thinking of public health as a matter of emergency. Yes, there are situations where evidence may be weaker and we may have less confidence, but isn't that the case all the time? And at times we have a lack of time, at times we need very contextual information. It's always a complex judgment. We need a quick pooling of data, a quick pooling of available evidence, and every time lost in the pooling of available evidence translates in deaths. It's very important that we can use, or that countries can use data from their region or from neighboring countries when they don't have their own data. And it's important that there are the proper surveillance system and the quick ability to monitor the situation and detect emergencies and if action should be taken and how. And also we need to use unpublished information. I mean, there's no way we want to wait for 2 years for a paper to be published before taking action, if it actually ever gets published, which may not be the case if it's again a negative paper or if it's a paper about showing the risk of vaccines. So in emergency situations, we need quick decisions, but also what we need is not quick decisions in a vacuum. So what we're trying to do now, SAGE has pushed us to establish a working group to develop a framework for use of vaccination in humanitarian emergencies. In other words, they don't want us or countries to take a decision in the vacuum when there is an emergency. They want a pre-established framework that will facilitate the issuance of faster decision making. Okay, so I just wanted to alert you to some process that has been ongoing with the European CDC, and they've tried to develop some guidelines on dealing again with emergencies and quick review of evidence, but it is more in the context of outbreak and specifically infectious disease. But I think it's worth acknowledging, and these guidelines are actually quite interesting. As part of this guideline, there's one element that I think is important that's of course, pretty basic, but important to keep in mind. It's the time it takes to have more confidence and more information. And you know, they are looking for short-term risk assessment, i.e. 2-3 days to take a decision versus having a luxury of time of 6 months to 2 years. And of course, it's correlated with the area of uncertainty. And the more time, the more you wait, the more you hopefully reduce the uncertainty. However, I don't think it's as simple as that. I think there are always uncertainties, always new questions that come up in immunization. And of course, we need to reduce the uncertainties to a minimum, but we have to live with them. Even in a Cochrane review, I mean, there is a lot, in my view, of decisions that are taken based on subjective judgment. I mean, the definitions, the inclusion, exclusion criteria, cutoff level. I mean, some of you may argue with me, but there's always some subjectivity in that process. So I think really what we need is a decision-making process that's not set in stone, but a process that evolves, and that is stepwise, and accepts actually to change its decision as evidence really evolves. And what is also important in my view, when you have limited data and you need perhaps more of expert judgment, you need expert judgment even with good data, it's the importance of a well-established neutral advisory body and the group that is meeting regularly. And that's what we have tried to do with SAGE. So there are very few topics that are actually seen as real emergencies at a global level that should be discussed in between the two 6 monthly meetings. And really what's essential is the importance of the updating of the recommendation. But again, you cannot do that without resources, and you cannot do that also without a call for more research to bring more information. And at times there's a tendency when a health intervention has been introduced to think, this is it. I mean, that's the end of the road and nothing more needs to be done. I mean, for us, it's really the beginning of the journey when the vaccine has been introduced. So with that, I just want to finish with this quote from Bradford Hill. All scientific work is incomplete, whether it be observational or experimental. It is liable to be upset or modified by advancing knowledge that does not confer upon us a freedom to ignore the knowledge we already have or to postpone the action that it appears to demand at a given time. And I think it's particularly illustrative of the message I tried to convey to you. And finally, I just want to thank you as a Canadian with a bit, of a Canadian touch. Thank you.
This was a question that actually came through Twitter. Somebody else wanted me to ask this. What did you think about recommendations about HPV immunization for males in the US?
Okay, well, I can tell you that at WHO, our global recommendations do not include the recommendation of vaccination of males, keeping in mind, again, the cost effectiveness and our prime target, which is basically the impact on cervical cancer. So there's no question that if you think about the impact on cervical cancer and the opportunity cost, all what you could do is using the same money for other health intervention, it doesn't rank very high for us. If the issue is, which I believe it is for the US, of the additional benefits of the vaccine, the tetravalent vaccine, which has also some affords protection against genital warts and some of the male cancers. I mean, there's an added advantage, but obviously for a very high cost. So what do I think of the US recommendation? It's not for me to say, it's for the US. They obviously have very different criteria to choose. For developing countries, it would be unmanageable to go for that because the price is very high.
Hi, Gunn Wist. I've been a co-member of the grade working group for the last 11 years. And I just want to point out, in case someone got confused there, we have not changed the rules. There has appeared suggestions and they will be discussed. There has as yet not occurred any change. Thank you.
Yeah, just to add to that, it's a good point actually that what I've actually presented, I mean, one would argue it's the straight, grade process. I emphasize it's an interpretation of the grade actually with the insight of grade, what we've done for population health. This adjustment, like what we've proposed for safety studies, have not yet been reflected in the published series in the Lancet Infectious Disease. We hope it will be actually, and we certainly hope to continue the discussion and evolve in that direction. And the same way where I said that for very strong and where there is consistency between studies, that also is still under debate. I mean, some people argue that why a criteria where you have only one possibility to upgrade versus all the others where you have one or two levels. But again, this is still under discussion.